Okay, welcome guys to the part 2 of our discussion. Okay, ngayon dahil alam na natin yung different ventilatory settings, yung mga ventilator modes, let us now look naman at the actual screen sa may ating mechanical ventilator. Okay, ito yung makikita mo guys every time na papasok ka sa ICU. Okay, this screen guys has 3 parts. Okay, we have here the client readings and the ventilator waveform and ventilatory settings. Sa client readings guys, ito yung actual na nare-receive ni patient. Yung ventilatory waveform naman guys, represents the breathing pattern of the patient. And this ventilatory setting, ito na guys yung in order ni doctor sa atin na i-receive ni patient. Ito yung ipoprogram natin based dun sa doctor's order. Okay? Now, unahin natin si ventilatory setting, diba? Makikita mo dyan na yung mode niya is what? AC. Anong ibig sabihin niyan? Assist control. Okay? Then the rate is 20 breaths per minute. The tidal volume is 500 ml. The peak is 5 cm of H2O. And the FiO2 is 50%. Ito na guys yung in-order ni doctor. Okay? Now, on the top of the screen, we have the client's reading. Okay? Yung ventilatory setting guys, ito yung gusto natin na mangyari sa patient. Okay? Ito yung in-order ni doc. But the client's reading guys is the actual na nare-receive ni patient. Okay? May napapansin ba kayo dito guys? Okay. Let's compare this one and this one. Okay? Yung setting natin, sa ventilatory setting, ang ilagay nating rate niya is 20 breaths per minute. Pero yung pinapakita ng monitor sa client's reading is 22 breaths per minute. Okay? Okay. Binago ba natin yung setting? Hindi. Hindi natin binago yung setting. Ang ibig sabihin lang nito guys, si patient ay what? Nagbigay ng 2 additional breaths. Okay? Diba guys? The patient can trigger an extra breath. Na-discuss na natin yan, diba? Okay. So, nagbigay tayo ng rate ng 20, but the actual reading, anong ginawa ni patient? Ano yung actual na nangyari sa kanya? Nag-take siya ng 2 extra breaths. Okay? Next, ano pa? Sa tidal volume, anong sinet natin? 500 ml. But the actual is 380 ml. Okay? Bakit hindi po siya 500 ml? Ibig sabihin lang guys, na itong dinisplay dito sa client's reading, ito yung what? It is the measured exhaled. Okay? Measured exhaled tidal volume. Or yung actual na na-deliver na volume. Okay? That one. Okay, how about the peak pressure? Ma'am, hindi nyo po yan na-discuss. Ano po ba yung ibig sabihin ng peak pressure? Okay guys, peak pressure meaning it is the highest pressure. Okay, it is the highest pressure that generated during inspiration. Okay, the highest pressure that what? Generated during inspiration. Okay, now, ano pang nakikita natin dyan? This one, the high pressure. Okay, bakit po ma'am may high pressure dyan tapos nakaganyan siya? Delikado po ba yan? Tapos nasa yellow bar pa siya. Okay? Later on guys, we will discuss the cause of different high pressure alarms and low pressure alarms. For example, ito yung nakita mo, pagpasok mo sa ICU, nakita mo yung monitor na may high pressure alarm. O ikaw ba, kailangan mo bang i-silence itong alarm na to? What do you think? Okay, the answer is no. Okay, kapag nakita mong may high pressure alarm, ano ang gagawin mo? You always assess the client or the patient first. Si patient muna ang a-assess mo bago yung monitor. Okay? Always yan guys. You assess the client first bago yung machine. Okay? Then mamaya, i-explain ko yung mga different high pressure alarms versus sa low pressure alarms. Then, lastly, the ventilatory or ventilator waveform. Okay, yan yung breathing pattern ni patient, diba? Okay, every peak, okay, represents one inspiration. Then, every downward slope naman represent exhalation. Okay? These are the different ventilatory settings. Now guys, we will talk about the intubation and mechanical ventilation. Okay guys, bago naman talaga ma-hook si patient sa mech vent, kailangan muna natin i-establish ang airway ni patient through the use of endotracheal tube or your ET tube. Okay? So intubation, ayan na yung tinutubuan si patient. Okay, so intubation involves inserting an endotracheal tube or your ET tube which serve as a artificial airway of the patient. Okay, it is inserted through the mouth and into the trachea where a cuff is inflated to hold it in place. Okay, like this one guys na nasa figure number 2. So sino ang gagawa niyan? The doctor will insert or the physician will insert the ET tube. Okay, so insert niya yan through the mouth. Yes, sa mouth yan pinapasok hanggang ma-reach niya si trachea. Okay, pag na-insert na yung ET tube, kailangan i-inflate natin itong cuff. Okay, to hold it in place para ma-secure natin yung ET tube dyan. Okay, Then after which, we need to confirm the tube placement. Okay, we immediately assess for bilateral breath sounds and symmetrical chest rise. Okay, pagka-insert niyan, then na inflate na yung cuff, we will insert here the ambu bag and then we introduce air. Okay, tapos si physician, dapat makarinig siya ng bilateral breath sound. Okay, so the physician will place the stethoscope, okay, the stethoscope on the, tawag dito, right and left chest ni patient. So, i-compare na yan. Kung may maririnig siyang breath sound dito, then may maririnig siyang breath sound dito. It should be bilateral breath sound. Equal dapat yung breath sound sa left and right chest ni patient or sa left and right lungs ni patient. Then, we will observe also for chest rise, okay, as we introduce air through the use of ambu bag. Okay, then they also use a ET or the end tidal carbon dioxide detector to ensure the detector changes from purple to yellow. This is to confirm an exhaled carbon dioxide and proper tube placement. Okay, yung end-tidal carbon dioxide, guys, kapag yung purple, nag-turn na siya sa yellow, ibig sabihin, guys, yun na yung exhaled carbon dioxide ni patient. So, ibig sabihin, nasa sa correct airway talaga tayo and confirm proper tube placement. But kapag yung purple, nag-stay lang siya into purple, ibig sabihin, nasa mali tayo. Mali tayo ng ininsertan. Okay, saan tayo naka-insert? Nasa esophagus tayo. And kapag nangyari yun, we act immediately. Okay? Then, obtain a chest x-ray to verify proper placement. This is the most reliable method, guys. Okay, this is the gold standard in checking if we are in the proper placement or correct placement of the ET tube. Ipa-x-ray natin si patient. Yung kanina, immediately assessment, yun to check if there is a bilateral breath sound and symmetrical chest rise. But the gold standard or the most reliable method is through the use of chest x-ray to confirm if we are in proper placement. Okay? Then we document the marked ET tube size and depth to recognize changes in tube positioning or dislodgement. For example, we have a 7.5 mm tube and 25 cm at a teeth like this one, guys. Okay, nakita nyo yan? Okay, bakit mahalaga yan na i-document natin? Okay, kasi guys, dito natin malalaman if there is an accidental extubation. Okay, for example, instead na 24 ang nakita mo dyan at a teeth, nasa 20 or 15, ganun na siya. Ibig sabihin, there is an accidental extubation that is happening to the patient. What if naman, mas dumip siya, 28, ganun. Baka ibig sabihin niyan, guys, yung dulo ng ET tube nasa ibig sabihin pwedeng nasa right mainstream bronchus na yung ET tube o di hindi na equal yung nadi-deliver na oxygen kay patient. Kaya dapat every shift, guys, i-check natin kung nasa proper placement pa tayo. We document the tawag dito, the any changes in the tube positioning or to check if there is a dislodgement. Okay, then we secure the tube to use a holder or tape to prevent accidental dislodgement. Okay. Now guys, once the patient is hooked or connected to the ventilator, ang next naman na responsibility natin is to respond to the ventilatory alarms appropriately. Okay? Kasi 'di ba kapag nakarinig tayo ng alarm, medyo yung magpapanik tayo. Okay? Kung ano yung ibig sabihin ng alarm na yon. Okay? Ventilatory alarms must remain on. Never turn off the alarms. Okay? Then if ventilator alarm sounds, always assess the client first, then the ventilatory or the ventilator equipment. So, number 1 golden rule yan, guys. Okay? You never turn off the alarm. Wag mo siyang papatayin. Kasi anong ibig sabihin ng alarm na yun, guys? Okay? Sinasabi ng alarm na yun that there is something wrong. Kumbaga, isa siyang safety feature ng mech vent. Okay? So, you never silence it permanently. Okay, dapat naka-on lang siya. Okay, now number 2, okay, or our second golden rule is to always assess the patient or the client first, then the ventilator. Okay, kasi mostly, yung iba, una nilang tinitignan yung machine bago yung pasyente. Dapat una mo munang tingnan yung pasyente. Tanungin mo sa sarili mo, humihinga pa ba yung pasyente? Meron pa bang chest movement? Or nagdedesat na ba yung pasyente? Kamusta ang kanyang oxygen saturation? Bumababa na ba? Or nagiging cyanotic na ba siya? Conscious pa ba yung pasyente? Yun muna ang una mong tatanungin sa sarili mo to check the patient first before the machine. And third, adjust the alarm parameter based on the client's condition to prevent excess alarm and alarm fatigue. Okay? Now, we have here the different ventilatory alarms. Tatlong problema ang pwedeng cause ng mga alarm na yan. Okay? Okay? We have here the ventilator circuit complication. Okay? Dahil ano yan ma'am? Okay, ito yung mga tubing connections, guys, that the ventilator connects to the client. Okay, tubing connecting ventilator to the client. This one, guys, yan. Anong cause niyan? Okay? Pwedeng may kinks, leaks, or disconnection. Number 2 na problema is endotracheal tube complications. Okay? Dahilan naman yan, merong kinks, obstruction, leaks, or dislodgement. Okay, dito mismo, the ET itself and the tracheal tube problem, the ET itself. Dahil merong kinks, obstruction, leaks, or dislodgement. And number 3 problem is client complication or the patient problems. Okay, anong possible cause nito? Pwedeng yung airway patency, the lung compliance, or the breathing patterns. Now we have here two types of ventilatory alarms. We have the high pressure alarms and the low pressure alarms. Okay, ma'am, ano po itong cause ng high pressure alarm? Ang cause niyan guys is due to increased resistance. Okay, anong ibig sabihin ng high pressure alarm niyan? Bakit may resistance, may increased resistance? Ibig sabihin lang guys na yung ventilator is trying to push air into the lungs, pero may nagbabara doon sa airflow, may blockage. That's why the pressure is high. Okay, for example guys, 'di ba nagmi-milk tea ka, okay? Nagsisip-sip ka ng straw, pero na-block yung straw ng pearl or ng boba pearl. That's why you need to suck harder para ma-generate natin yung higher pressure. So parang ganun nung nangyayari sa high pressure alarm. Now, we also have a low pressure alarm. Okay, anong dahilan nito? Due to decreased resistance. Okay, instead na ma-meet natin yung resistance, yung air lumalabas or nag-e-escape before the air will reach the lungs. Okay, ma'am, paano yan? Okay, for example guys, you want to inflate a balloon. Okay, pero yung balloon na yon merong butas. Okay, so hinihipan mo yung balloon pero hindi siya nag-i-inflate kasi nga lumalabas or naglilik yung hangin. The pressure never build up. Okay, ganun siya guys. That's the cause of your low pressure alarms. Okay? Tingnan natin guys yung table number 3. Okay? We have here the ventilator alarms. Okay, we have here first the high pressure alarm. It is triggered by increased resistance or high resistance. Okay, resistance to what? Okay, resistance to airflow entering the lungs, di ba? Kasi yung ventilator guys is trying to push air into the lungs, pero merong nagbabara dun sa pathway na yon. Okay, ano yung mga causes? We have here obstruction. Okay, this example guys is ang cause niya is obstruction. We have here number 1, coughing. Okay, kapag umubo yung pasyente, okay, the airway will suddenly narrows and the pressure inside the airway also increases. But once na tumigil na umubo si pasyente, magi-stop na din yung alarm. Okay, second, we have bronchospasm due to obstruction. Di ba pag may bronchospasm, nagiging narrow yung airway. Di ba? May constriction na nangyayari. Okay, next, secretion. Obstruction ulit yan. Okay, bakit may secretion? For example, merong thick mucus na na-build up doon, blocking the ET tube. Okay, obstruction due to secretion. Mahihirapan yung air na dumaloy due to the mucus build up. Okay, nag-plug siya doon. Okay, next, we have client biting the ET tube. Okay, si pasyente ang may problema, kinakagat niya yung ET tube. Kung kinagat mo yon, mas tataas yung pressure, kaya may high pressure alarm. Okay, so nabablock niya kasi or partially nabablock niya yung ET tube. The air cannot pass easily. Okay, then kink tubing. Okay, minsan, hindi si pasyente ang problema. Simply, yung tubing is may kink or nag-bend. Alam niyo naman yung itsura nung ganun kink, di ba? Nag-bend yung tubing. Ganun yung kink tubing, guys. So magi-increase yung ganun dyan, yung airflow resistance. So, yung cause ng high pressure alarm, guys, sa madaling sabi is due to obstruction. Now, kapag narinig natin yung mga high pressure alarms, guys, ito ang gagawin natin, our nursing interventions. Okay, number 1 is to suction as needed. Lalo na kapag ang cause ay due to secretion, di ba? We remove the obstruction. Okay, for example, mga mucus yan, once the mucus is removed, then matatanggal na din yung high pressure alarm. So, suction as needed. Okay? Then, reposition the client. Bakit? Okay, sometimes, guys, yung neck position or yung body position ang nagkukos ng kink sa ET tube. So, changing the patient position will restore the airflow. Okay? Then, insert a bite block if needed. Okay? Or mouthpiece. Okay? Lalo na kung nilalabanan ng pasyente yung ET, kinakagat niya. Pwedeng si patient is nagiging restless. So, we insert a bite block to protect the tube, okay, from being occluded. Then, we assess the tubing for kinks or obstruction. Okay? Simply, checking it. We inspect the ventilator tubing. Okay? Tingnan ba natin kung nakabend ba ito? Or nakompress ba siya ng mga bed rails? Okay? Ganun siya, or if there is an obstruction. Okay? Those are the different interventions for your high pressure alarm. Moving on to low pressure alarms. Okay, ano naman nangyayari dyan sa low pressure alarms? It is triggered by pressure drop. Okay, pressure drop. Low pressure, there is leak. So, ang problema niya, ng cause niya, okay, ang main cause is due to disconnection or leak. Bakit na-disconnect? Okay, bakit low pressure ang tunog? Kasi nga, the air escape before reaching the lungs. Okay, anong mga cause? Tubing disconnection. The ET tube cuff is leak. Yung cuff, guys, yung in-inflate, diba? Kailangan naka-inflate yun. So, kung naka-deflate yun, the air will escape. Hindi siya makakapunta sa lungs. Okay? Now, our nursing intervention, dahil may disconnection, of course, we reconnect the tubing and then assess for cuff leak. Okay? Yun, guys, yung mga different ventilatory alarms. Next guys, okay, we also have complications of ventilation. Yes, meron din complication ang na ibibigay ng neck vent. Mechanical ventilation can cause several life-threatening complications. We have here number 1, barotrauma. Okay, baro means pressure. Okay, so pressure trauma. Okay, bakit magkakaroon ng barotrauma? Due to excessive lung pressure from a high PIP. O, diba? Excessive lung pressure from a high PIP o high PIP ang ginamit kay pasyente. Definitely, kung high PIP ang ginamit sa kanya, pwede niyang ma-overstretch or ma-overdistend ang mga alveoli. O kapag na-overstretch yan, okay, pwedeng mag-rupture ang alveoli. Thus, the air will escape, okay, into your pleural cavity. Kapag nag-escape siya sa pleural cavity, will lead into your pneumothorax. Or that air can also escape to your skin. Ang tawag doon is subcutaneous emphysema. Okay, paano mo malalaman na may pneumothorax na si patient? Diba? Kapag decrease na ang lung sound on the other side of the lungs. Decrease na, wala ka nang marinig ni na breath sound. Okay, ano pa? Meron na, ano yung late sign? May tracheal deviation na nangyayari. Ibig sabihin, may tension pneumothorax na si patient. Paano naman sa subcutaneous emphysema? Okay, when there is crepitus, okay, or crackling sound in the skin. Ang tawag doon subcutaneous emphysema. Okay, next complication is hypotension. Bakit yung neck vent, nilolower niya yung blood pressure? Normally guys, di ba anong ginagamit natin? Negative pressure. Sa pag-breathe natin, di ba? That negative pressure guys helps draw the blood back into the heart. Pero dahil naka-neck vent si patient, positive pressure ang ginagamit dyan. That positive pressure will compress, okay, the thoracic vessel. Now leading to decreased venous return to the heart. Kasi nga, di ba na-compress? So kung decrease ang venous return sa heart, ibig sabihin yan, magdi-decrease din ang ating cardiac output. Kaya remember guys, when you are using a high PIP, okay, ibig sabihin, high risk ka din for developing hypotension. Okay? We also have here the ventilator-associated pneumonia or your VAP. Okay? Due to colonization of bacteria in the ET tube. May nabuong bacteria dyan. Okay? Plus, microaspiration of secretion. Then, na-aspirate mo yung mga na-colonize na buong bacteria sa ET tube, thus increasing the risk of developing pneumonia. Okay? Then also, we have other complication like stress ulcer. Nangyayari ito sa mga critically ill na patient due to physiologic stress. Okay? Yung mga critically ill na patient may experience a significant physiologic stress. O dahil stress, merong stress na nararanasan, there will be a reduced blood flow in the stomach. Now, dahil decrease ang blood flow sa stomach, the gastric lining, okay, become more susceptible to injury. So, stress ulcer may develop, okay? Yung ulcers may develop into the stomach, okay? Now guys, moving on to caring for ventilated clients. Okay, nursing care for clients receiving mechanical ventilation focuses on 4. Apat yung focus natin. Number 1, maintaining airway and adequate oxygenation. Of course, that's our number 1 priority. Second is promoting comfort and nutrition. Third is preventing the VAP or the ventilator-associated pneumonia. And lastly, supporting weaning from ventilator. Okay, isa-isahin natin ang mga yan. Okay, number 1 is to maintain an airway and adequate oxygenation. Okay, we keep a bag valve mask or yung ambu bag at the bedside to provide manual ventilation if ET tube becomes dislodged or client is accidentally extubated. So always at the bedside guys, dapat available lang ang ating ambu bag or ang ating bag valve mask. Okay, in case na ma-accidental extubate si patient or ma-dislodge yung ET, we need to manually ventilate the patient using the bag valve mat. Okay, then assess ET tube placement or teeth or lips every shift and after repositioning client to confirm it hasn't shifted from the original depth. O yan na yung sinasabi ko kanina guys, na importante i-document natin yung tawag dito, yung size and yung depth ng ET tube. Kasi guys, doon natin malalaman kung na-displace ba ang ET tube. Okay, kailan ba siya pwedeng ma-displace? Kapag nag-reposition tayo or kaya dapat every shift and every repositioning, i-check natin, okay, kung nasa tamang placement pa ba tayo. Okay, to confirm it hasn't shifted from the original depth. Okay? Then we also assess the breath sound, the respiratory effort, and pulse oximetry reading frequently. Okay? Assessing the breath sound. Okay? Possible ba na nag-worsen ang condition ni patient or nag-i-improve na? Kung nag-worsen yan, ano yung maririnig natin? Kung may wheezes, stridor, ganun. The respiratory effort, kung nagiging okay na ba si patient or mas nagiging worse. O, kapag si patient gumamit ng mga different accessory muscles, ano pa, and pulse oximetry. Siyempre, kailangan natin i-record kung anong magiging oxygen saturation ni patient, kung nagdedesat pa siya, kung enough ba yung ventilator support na binibigay kay patient. So, we need to monitor that, okay? Frequently. This is for monitoring, guys. Also, the ABG result and vital signs closely. We need to monitor that para malaman natin kung nagiging okay na ba si pasyente or mas kailangan pa niya ng tulong from the mechanical ventilator. Okay? Then we also maintain adequate sedation to improve ventilator tolerance and decrease risk for self-extubation. So bakit pwede nating i-sedate si patient natin dyan? Okay? The sedation will help the patient reduce anxiety. Okay? Ano pa? To improve patient comfort and to also improve the ventilator synchrony. Okay? Thus, kapag nakasedate si patient, okay, minimal sedation lang guys, para mabawasan ang oxygen demand ni patient. Okay? Or decrease the oxygen consumption of the patient. And then, of course, kapag naka-minimal sedation si patient, maiiwasan din natin yung accidental self-extubation. Pero guys, too much sedation naman is also harmful. Kaya ulit-ulit kong sinabi na minimal lang dapat ang sedation ni patient. Because that over-sedation will delay the weaning. Okay? Madedelay niya yung weaning ni patient, thus increasing the risk of delirium pa. Okay? Ang goal natin sa pag-sedate, dapat maging comfortable si patient, dapat maging kalmado lang siya. But the patient is easily arousable. Okay? Unless kailangan niya ng deep sedation. Okay? So si doctor naman ang magde-determine nun. Okay? Then apply a wrist restraint. Okay? As a last resort to prevent unplanned extubation, di ba? Sabi dito, last resort. Alam niyo yung wrist restraint, guys, yung tinatali yung wrist niya, okay? Kasi guys, merong mga pasyente na nagse-self-extubate, tinatanggal nila yung nakatubo sa kanila, okay? Ang paglagay natin ng restraint, guys, is sa fundamentals, dapat last resort yan, okay? Lalo na sa mga confused na patient. However, before restraining the patient, guys, okay, always try, okay, to orient the patient first. I-reorient mo siya. And of course, kung may family member, pwedeng ipabantay natin sa kanila, okay? Then we provide pain control, okay? Then we also adjust the sedation. Then another alternative safety measures bago tayo mag-restrain, okay? Then according yan pa sa institutional policy yung pagre-restrain dyan, okay. If accidental extubation naman happen, we apply oxygen, administer breath with the bag valve mask as needed, and immediately notify the healthcare provider. Ito ang gagawin natin, guys, if there is an accidental extubation. Okay, we manually ventilate the patient using the ambu bag, and we immediately notify the healthcare provider. Okay? Second is promote comfort and nutrition. Okay? Titrate sedation and analgesia to maintain comfort while keeping the client awake and interacting with the environment. Guys, magkaiba ang sedation sa analgesia. Si analgesia is mainly for pain. Si sedative naman is to reduce the anxiety of the patient. Okay? Use pain and sedation measurement tools like the RASS to guide the titration, guys. RASS means, okay, RASS means the Richmond Agitation Sedation Scale. Again, it is the Richmond Agitation Sedation Scale. Dito guys, dine-determine if yung pasyente is agitated, kung kalmado ba siya, lightly sedated, or deeply sedated. Okay? Then we also need to do the spontaneous awakening trials or the SAT. Okay? Post-sedation to assess underlying neurologic function and decrease risk for over-sedation and delirium. Ma'am, ano po yung spontaneous awakening trial or SAT? Okay? Ini-stop dito or pinopause saglit yung sedation. Okay? Para ma-assess kung conscious pa ba si patient ay nakakapag-follow pa ba ng ating command, and to assess the neurologic function of the patient, and of course to assess to ready na ba na i-decrease natin ang kanyang sedation. Kasi too much sedation, guys, can hide the patient neurological status. Okay? That's why madidali na yung ventilator weaning natin. Kaya siya pinopos ng saglit. Okay? And of course to decrease the risk for oversedation and delirium. Okay? Then we reposition the patient frequently and monitor for skin around the pressure point or the ET tube holder. Of course, guys, di ba? If the patient stays in one position, pwede naman ma-develop yung mga pressure ulcers, di ba? Then kapag matagal lang siyang nandun sa position niya, walang mobility nangyayari, secretions will build up or will pull into the lungs, okay? Kaya nagre-reposition din tayo ng pasyente. Then we also perform a range of motion exercises as tolerated to prevent muscle weakness and contractures. Okay, that this is to maintain the joint mobility and to prevent contractures. Okay, then next, facilitate communication with alternative communication tools like the use of your communication boards and writing tools. Okay, na-try ko na yun guys, makipag-communicate sa mga naka-mech vent, nakatubong pasyente. Okay, ang hirap makipag-communicate kasi hindi nila medyo ma-express yung sinasabi nila kasi nga may tubo sa kanilang bunganga. So binigyan ko sila ng whiteboard noon, tapos pen. Tapos sinusulat nila, doon ako nakikipag-communicate nung nag-duty ako sa ICU. Then we also initiate the enteral nutrition within 24 to 48 hours of intubation to maintain the normal gut motility. Usually guys, yung mga nakatubong pasyente, ang means ng kanilang nutrition is through the use of your nasogastric tube. So usually nakatubo sila. Syempre, di ba may may tube, tube na nakabara sa kanilang bunganga. So, yung pagkain nila dapat enteral nutrition. So, naka-NGT si patient dyan. Okay? Then, administer proton pump inhibitor or your PPI or H2 blockers to prevent the development of stress ulcers. Okay? Okay, next. Okay. Our third intervention is to prevent the ventilator-associated pneumonia or your VAP. Okay, to prevent that, we need to do this 5-element VAP bundle. Okay, this is an evidence-based, guys. Once na si patient ay naka-MEC-vent, kailangan mong gawin ito. Okay, we need to maintain the head of the bed at 30 to 45 degree to decrease the aspiration risk. Okay, this is one of the component of the 5 elements VAP bundle. Okay, we need to perform oral care with chlorhexidine every 2 to 4 hours. Diba? Yan, mag-oral care tayo kay patient to prevent na mag-accumulate yung mga bacteria doon. Kung may nag-accumulate ng mga bacteria, it can cause microaspiration, thus leading to ventilatory-associated pneumonia. Then we suction only when indicated. Okay? Kailan ba tayo magsa-suction? Suction as needed when there is visible secretion. Okay? Kapag nagde-desat na si patient, makikita mo naman sa pulse ox niya yan. Okay? Then kapag may presence of bronchi na when you auscultate lung sound. Okay? Do not suction routinely due to increased risk of infection and hypoxemia. Kaya nga po ulit-ulit natin sinasabi, guys, na suction as needed only. Then use a closed suction system or your inline suctioning when possible to maintain a sterile technique if open suctioning is necessary. Yes, guys, ang pag-suction is sterile technique. Okay? Then follow the appropriate suctioning technique. Okay? Bago tayo mag-suction, guys, ito yung mga step na gagawin natin. We need to hyper-oxygenate the patient. Okay? Paano yan? Okay, pindutin natin yung FiO2 niya. Ilagay natin ng 100%. We hyper-oxygenate the patient. Okay? Pipindutin mo lang yung MEC-vent. Okay? Yung FiO2 na 100% before suctioning. Then advance the catheter until resistance is met. Paano mo malaman na namit mo na yung resistance? Kapag umubo yung pasyente or kapag na-reach mo na si carina. Okay, ano yung carina? That separates your right and left bronchus, di ba? Kapag na-reach mo na siya, may naramdaman ka ng resistance, you withdraw it slightly. Mga 1 inches mo siyang i-withdraw. Then you suction it intermittently. Then, saka mo siya i-apply. Apply suction while withdrawing the catheter. Okay, intermittent suctioning. Okay, do not suction with inserting the catheter. Then, suction only for less than 10 seconds to prevent hypoxemia. Okay, then ibalik mo na ulit yung oxygen ni patient. Okay? Next, support weaning. Okay? Yung weaning, unti-unti na natin siyang tatanggalin sa MEC-vent. Okay? Weaning is the gradual process of decreasing the ventilator support as the client regains the ability to breathe independently. Okay? Then assess client for weaning readiness. Ano yung mga signs na ready na si patient na ma-wean sa ventilator? Okay? Dapat okay na yung breath sounds niya, wala nang paggamit ng accessory muscles, and so on and so forth. Okay? So, when you assess for readiness, the client should be well-rested, cooperative, and alert. Then we conduct a spontaneous breathing trials. Okay? This spontaneous breathing trials is done into a brief period only. Okay? Brief period of unassisted breathing. So, yung settings na binigay natin lang kay patient kapag naka-spontaneous breathing trial siya is pressure support only. Okay, na-explain ko na yan kung ano yung pressure support. Okay, with closely monitoring to decrease the risk of prolonged intubation. Now, we also use a supportive strategies. Okay, ano yung mga supportive strategies natin? We minimize the sedation, we provide respiratory therapy, and optimize nutrition through the use of your enteral feeding. Okay, we monitor for signs of weaning intolerance, like takip niya, tumataas ang heart rate, okay, nagdedesat si patient, anxious si patient, and the use of your accessory muscles. Okay, if signs of respiratory distress occur, we resume the full support ventilator mode as needed. So kung naka-pressure support siya, tapos merong weaning intolerance, ibabalik natin siya sa full ventilatory mode. Okay? Then prepare for extubation. Okay, paano extubate? Dapat meron tayong laging nasa bedside na bag valve mask or the ambu bag. Also, the crash cart and the suction at the bedside. Then assess for signs of airway complications like stridor. Baka mas lalong nag-narrow na yung malalaking airway. Ang maririnig mo dyan is stridor after the tube is removed. Then hoarseness of voice and sore throats are expected findings after the extubation. Siyempre, may pinasa tayong tubo sa kanyang bunganga. So, expected ang hoarseness and sore throat after extubation. Okay? This is the 5-element VAP bundle, guys. It is an evidence-based, okay, practice, okay? Number 1, we need to elevate the head of the bed at least 30 to 45 degrees to decrease the aspiration risk. Then, oral care ng chlorhexidine, okay? Then, stress ulcer prophylaxis, the use of your proton pump inhibitor or the H2 blockers. Then, daily sedation assessment and spontaneous breathing trials. And lastly, the deep venous thrombosis prophylaxis, okay? The use of anticoagulants, okay? That's all, guys, for your mechanical ventilation. I hope you learned something. Thank you and God bless.